Welcome back to our final session of the day, and this one is all about innovation. Who's doing what really well, and how can we borrow some of those ideas? We're going to hear about people using digital technologies. We're going to hear about what ARTROs are doing. But first of all, a consumer perspective. Our first speaker is Darlene Cox. She's working with consumers to drive sustainable and quality use of medicines. Over to you, Darlene.
I'm not a client scientist. And I'm not a healthcare worker. I'm an active user of health services and a consumer representative, and it's from these perspectives that I'm going to speak to you today. I think about the carbon footprint of the care I'm using while I'm receiving care, while I'm travelling to medical appointments, while I'm waiting for images and blood tests and using medication. It's a very resource-intensive industry. Sometimes my partner says I overthink things, and probably she's right. But I think the impact of climate change on healthcare and the impact of healthcare on climate change is something that warrants our attention. And clearly others do too, evidenced by the impressive group of people we have here today, participating as speakers, panellists, and the people registered to attend. Much like the planet, we all have a tipping point, and mine came at the end of 2019 with the Black Summer. We watched the smoke cloud approach from the southwest, and we did what we could to prepare. Our daughter-in-law at the time was heavily pregnant, and she was struggling with the heat and the poor air quality. Seeing her fear of what the smoke was doing to her growing baby was really quite confronting. And look, like you, we've had family members who found it challenging with their asthma and also with anxiety. The smoke and poor air quality was really having an effect on our family. Our family had many conversations during that time about the impact of climate change and on our health, and we continue to have those conversations. Now, that little baby was born a month before lockdown. He was in good health, but, we worried about the impact of climate change, not on him at that stage, but into the future. And that was my tipping point. Since then, I've been really focused on actions to reduce the impact of healthcare on our environment. Environmental sustainability is a focus of mine. I do it through my advocacy, and I also do it in my own personal engagement with health services and the healthcare that I use. I worry about the hugeness of the problem and the smallness of our ability to do anything about it. Eco-anxiety is a legitimate reaction to the climate crisis. The challenge is dialing back on the eco-despair and taking on what actions we can to reduce carbon emissions. And that's the challenge. I know I'm not alone in worrying about this. Many of us are talking more and more about the carbon footprint of healthcare and what action we can take individually and, importantly, collectively. Climate change is an environmental, social, and governance issue and needs to be addressed by governments, corporations, and individuals. We, at all levels, need to do our part. Today, I want to share my perspective on this topic and a few things I've been doing. And it's based on many conversations I've had with consumers and carers, and that's the challenge. I know I'm not. Eco-anxiety is a legitimate reaction to the climate crisis. The challenge is dialing back on the eco-despair and taking on what actions we can to reduce carbon emissions. And that's the challenge. I know I'm not alone in worrying about this. Many of us are talking more and more about the carbon footprint of healthcare and what action we can take individually and, importantly, collectively. Climate change is an environmental, social, and governance issue and needs to be addressed by governments, corporations, and individuals. We, at all levels, need to do our part. Today, I want to share my perspective on this topic and a few things I've been doing. And it's based on many conversations I've had with consumers and carers. It's not a sermon, and I'll resist the temptation to proselytise, but I know it's so dependent on our own personal values and our own personal resources, our capacity to change. But I'll give you a few things to think about. There are clear areas for action for the health system. First, keeping people healthy so our need for healthcare reduces. The second, reducing the incidence of low-value care. Third, prioritise quality use of medicines and diagnostic technologies. And the fourth, let's decarbonise the healthcare system to reduce greenhouse gas emissions and therefore the carbon footprint. These actions mean we need to change the way we do things. We know change is hard. In 20 years as a consumer rep, I have attended many, many meetings, and before COVID, almost all of them required travel. Thanks to the pandemic, we've learned how to hold virtual meetings, reducing unnecessary travel. Like, do we really need to fly to another city to meet people? Honestly, how can we justify that anymore? So I've decided whenever possible, I'm not going to use air travel for work or leisure. Instead, I'm going to join conferences and meetings online. Virtual care is another option for us to embrace. It can reduce carbon emissions relating to transport, but it does come with a critical caveat about equity. Virtual care can help consumers receive more appropriate and timely care, and it does reduce carbon emissions. COVID-19 accelerated our adoption of virtual care, making it now an essential part of the way care is delivered. In just a year or two, we made a decade's worth of progress. We can't afford to go back to pre-pandemic health care delivery. We have to take advantage of the progress we made. So the caveat is that we need to think about this in terms of equity, because it can worsen existing health disparities, because not all consumers have access to the technology or the broadband, or we may not have the digital literacy required to engage effectively. So all of that will vary widely among individuals and communities, and it can reinforce existing inequity. So we need to be mindful of that. So here's a picture of my bathroom medicine cupboard. Does anyone else look like this? Expired medicines, tablets you don't need anymore. Yeah, it's quite a picture. It underscores that waste is a significant issue. In the waste, like there's waste in packaging, there's wasted prescriptions, which, medications that aren't picked up, or they're picked up and not used, or they're flushed down the toilet or put into landfill. Sometimes we're taking more medications than we necessarily need. Waste exists all along the chain, and there are actors at every step that can make a difference, and that's what we need to be focusing on. Consumers, we can sort out our cupboards and we can return unwanted medicines for safe disposal, and we probably need to promote that more. Storage of expired and unwanted medicines in the home can be dangerous and unsafe, and the disposal can lead to environmental damage with potential toxic impacts on flora and fauna and reduction in the quality of drinking water. That return of unwanted medicines, or the RUM project, is great for that. It's easy and free to dispose of unwanted medicines responsibly at a local pharmacy. Often the messaging about unwanted medicines and returning them is focused on safety. But I think it's important that we need to think about messaging that emphasises the environmental damage of medicines in the system. This may encourage people, in fact, to act and bring medicines back for disposal by pharmacists. Another thing we can do is recycle blister packs. Blister packs are a mixed blessing. They keep medications safe and contained, but they also create an amazing amount of waste. I'm fortunate enough to enjoy good health and not take a lot of medication, but recently I was struck down by one of the circulating viruses, thanks to our grandson. And during that time, I took a lot of tablets, pain relief and antibiotics. And the image shows the collection of blister packs just from that time. I was quite amazed at just how much was there. Blister packs can't be recycled in your normal council recycling bin, but there are places that take them. The challenge is for us to make sure as many people as possible know about it as an option. I was talking to my mum about this, and I was really pleased that she knew about it. Her local pharmacist is in Western Sydney, and they told my mum about it. My dad's on a lot of medication, and so they've often got lots of packaging left over, and mum was really pleased that she was able to recycle it. I'm also interested that some of the community pharmacy chains are actually including information about this on their websites, almost like a point of difference. So there's a competitive advantage to those community pharmacies who are using it. Here's a couple of examples. And then, of course, we've got Pharmacycle that's really now engaging and providing options for recycling. So all these small acts can contribute to the bigger picture. Another thing I'd like consumers to be thinking about is home medicines review. We can review the medication that we're taking and talk to our doctors and local pharmacists about maybe low carbon prescribing. Home medicine reviews are really useful option to reduce unnecessary medication and safely dispose of those medications that we don't need. But I'm surprised at how few people are aware of home medicine reviews and take them up. It's such a useful service to help you work out if you're using your medicines correctly, that they're working for you, and how to get rid of those unwanted ones that clog up your bathroom cupboards. Another element of this is the need to talk about reducing low-value care. For many years, I've been involved in Wiser Healthcare, and it's a research collaborative made up of researchers, clinicians, and consumers. It's working to reduce overtreatment and overdiagnosis. Reducing low-value care has the potential to cut healthcare carbon emissions, while at the same time safeguarding the quality of care and ensuring the patient outcomes aren't adversely affected. Choosing wisely is another opportunity to improve the environmental sustainability. The recommendations of colleges and health professional bodies around changing practice can make a difference. I'm also wondering whether the 5 questions to reflect could reflect the environmental impact of some of the tests and the medications that we use as well. So if we're at the position of reviewing the 5 questions, why can't we look at it through that lens too? Medicines are a common and important treatment option, but we can also think about non-pharmacological interventions. Now, I'm not saying walk away from pharmacotherapy. Unquestionably, medicines save lives and improve our function and support quality of life. Yet, we need to think about significant environmental footprint and look at alternatives where we can. So there are alternatives that have demonstrated benefit, and especially for mental health and well-being, chronic conditions management. Nature prescribing may improve physical activity, blood pressure, social connection, and also mental well-being. And primary care clinicians can recommend nature-based therapies or activities, green spaces like going for a walk in the park or a run, if that's what you like to do, going for bushwalks, spending time with the trees, grasses, and in your garden. Or you can go to blue spaces, such as rivers, coastlines, and wetlands. Again, there's equity issues, as COVID taught us that not everyone has access to safe green or blue spaces, and we need to think about that as we're designing and building new communities and new urban spaces. Social prescribing is another alternative. It involves referral to non-clinical services such as community groups or services for practical and emotional support. Recently, I did something I try not to do, and I bought a bottle of water. I was faced with several options, but I chose this one. They claim to offset carbon emissions by purchasing carbon credits. Now, is this greenwashing? Probably. I don't know. But it did make me feel like I was less like I was harming the planet through my purchase. It made me think about similar options for medication, though. Can over-the-counter medications have a symbol to show the manufacturer is offsetting their carbon emissions? And can we build in details of the environmental impact of medications into clinical decision supports? This would require a change in government policy and enforceable and enforcement, but it is possible. All of this relates to health literacy. Health literacy can help us prevent health problems, protect our health, and better manage health problems when they arise. I was really surprised that health literacy was not addressed in the draft National Climate and Health Strategy. There seems such an odd omission. We know how important health literacy is to consumer empowerment. It's also needed to bring about change in behaviour to support mitigation and adaptation and build our resilience in a changing climate. Health literacy has to be included in the final climate and health strategy. People can't shift the dial on our own. Government plays a really important role. I've been a member of the advisory group with the Commission for the development of the Sustainable Healthcare Module. It's recently undergone public consultation, now winding its way through the Commission's approval processes. The module uses systems to establish a foundation of actions that mitigate further contribution to climate change. It's requiring health services to review their clinical practices and identify unwarranted clinical variation and the unnecessary use of resources. There's a real focus in this module on changing practice to reduce unnecessary or even harmful tests, procedures. It's going to require health services to have better waste management systems in place and also reduce unnecessary travel. It'll require health services to review and improve their energy and water use, and it has an underlying focus on quality and safety and management of medicines. So all that is music to my ears, and it goes hand in hand with the revision of health practitioners' codes of conduct, as well as the work with the Australasian Health Facility Guidelines and building standards that are also requiring better design. As the climate crisis is harming human health, we all need to pitch in to reduce our carbon footprint. This includes all the players in healthcare. I'm talking about the pharma companies, other manufacturers of devices, hospitals, doctors, surgeries, diagnostic imaging, pathology, community pharmacy, health insurers, and regulators. We all need to play our part. The success also relies on ensuring consumers and carers and families understand the need to change the way healthcare is delivered so we can decarbonise the health system. So my question to you is, what changes can you make? How can you use your own role, your skills, professional networks, knowledge and experience to start to make the changes across our communities? We all need to do something so we have there's better health for us and better health for our planet. Thank you.
Thanks, Darlene, for that important consumer perspective. And I did promise you that we were going to hear about digital innovations as well. That's now. Dr. Paul Miles is going to be talking about how digital health technologies promote the appropriate use of medicines and contribute to sustainability.
Hello, I'm Paul Miles, the Director of eHealth and Medication Safety at the Australian Commission on Safety and Quality in Healthcare. I have the privilege of working with extraordinary pharmacists, safety experts, and support staff who are committed to achieving more appropriate use of medicines by using digital health technologies. Before my time at the Commission, I was a hospital manager working in several public hospitals across Sydney. I've seen firsthand the duplication, waste, and harm that can occur. This leads to a less sustainable health system characterized by unwarranted clinical variation, limited workforce productivity, and safety issues at transitions of care. Inefficiencies in the healthcare system, from medicines production to inappropriate prescribing, can also have significant environmental ramifications. Incorporating sustainable practices in healthcare settings must be at the forefront of everything we do, and this, I believe, can be realized by digital health. There are a vast array of digital health solutions which can bring about their own unique challenges and unintended consequences. An emerging safety priority is to seamlessly integrate digital health technologies across all sectors of the healthcare system. You might be familiar with some technologies listed on the screen. What my team and I hear from healthcare professionals is how challenging it can be to connect these technologies. The connection, or interoperability, between technologies supports the seamless information flow across the system, enabling timely access to precise, contemporary information for better care. Whilst we should celebrate examples of interoperable digital health technologies, what is more important is the resulting outcome. One less medication error, one less test, one less admission. To get the full benefits of digital health, we need to get these connections working. If we can make progress in areas like interoperability and transitions of care, then we will see improved system sustainability, less low-value care, more efficiency. The consistent application of national safety and quality standards, underpinned by technical infrastructure, can support a more connected healthcare system for safer transitions of care. This is when all or part of an individual's care is transferred between healthcare locations, providers, or levels of care within the same organization, or if an individual's condition and care needs change. Coordination and collaboration between healthcare providers is foundational to appropriate use of medicines at transitions of care for a more sustainable health system. The Commission's National Standards Program promotes the use of national health identifiers and terminologies, both of which are foundational safety elements that support effective communication for safety. Australia's response to the World Health Organization's Global Patient Safety Challenge, Medication Without Harm, showed that establishing and implementing medication documentation and communication standards across all transitions of care can lead to a reduction in medication errors and adverse drug events. Digital health technology supports pharmacists and consumers to use medicines more appropriately. For example, electronic portals can improve medication adherence and reduce unused medicines from entering waste reservoirs. The digitalization of healthcare provides greater opportunities to generate and harness data to inform decision-making. Standardized atomic data can enable greater data sharing and analysis to more efficiently manage low-value prescribing practices and identify trends in medication errors. The Commission's standards and tools are informed by overarching policies and strategies. The Commission's Digital Health and Medication Safety Program are driven by the National Digital Health Strategy and National Medicines Policy. Digital health technology is reflected in resources that are designed to support health services meet the medication safety standard. The role of digital health technologies is likely to feature even more in future editions of the National Safety and Quality Health Service Standards. Governments, health services, and other delivery partners must work together to ensure the sustainability of resources needed to support the health system. Australians are high consumers of medicines with approximately 315 million PBS prescriptions dispensed in the 2021 financial year. Any use of medicines could result in medication-related harm, particularly without suitable medication safety measures in place. The mismanagement of medicines contributes to poor outcomes, demonstrated by an estimated 250,000 medication-related hospital admissions each year, coming to a cost of $1.4 billion. Encouragingly, we have a more digital-minded workforce than ever before to address these challenges. Clinical informatic roles such as chief pharmacists, information officers were not as prolific 10 years ago when compared to today. So it's no surprise that the pharmacy workforce, who are typically embracers of digital health, have so many medication management technologies to help achieve more appropriate use of medicines. Virtual care can elevate how healthcare providers deliver services to as many patients as possible. For example, electronic medication management systems can enable more patients to have access to timely medication reconciliation, medication review, and patient education about new and changed medicines at discharge. Digital health technologies have overcome geographic barriers to care provision, resulting in stronger partnerships between rural and metropolitan health services. This can support and potentially even extend on the services provided by rural health services. These hub and spoke care pathways can expand equity and access for rural patients to tertiary referral specialist services. By bringing care to the patient via digital health solutions, both time and carbon emissions from transportation can be reduced. It is important that digital health infrastructure focuses efforts on minimizing any environmental impacts. The same mindset can be broadly applied to health service development. How to build an environmentally conscious digital hospital for the future. The rapid uptake of digital health technologies, particularly virtual models of care, will require robust and fit-for-purpose clinical governance frameworks. Health services will need to consider how clinical governance guidance that may have been originally designed for conventional, face-to-face models of care can apply to a virtual setting. More resources are needed to support health services commencing their digital health journey. This begins with the procurement process. Procurement can bring about many opportunities for safety and sustainability. Guidance for health services to procure digital health technologies, particularly for medication safety, can encompass technical specifications and clinical safety elements. Demonstrated environmental sustainability, such as manufacturing and packaging practices, can be a condition of prospective vendors. Better inventory management from digital health technologies can reduce excess stock and waste. Better inventory management could also be used to minimize impacts from medication shortages. Digitally enabled medication management can facilitate medication review processes, which can lead to more effective deprescribing of medicines. This is particularly important to reduce low-value care and low-value prescribing, both of which yield little clinical benefit for the patient and depletes the system of valuable resources. The intersection between pharmacy practice and digital health is critical to realizing benefits and medicine sustainability. Digital health technologies like electronic prescribing and electronic medication management systems can achieve a substantial reduction in medication-related error. Hospital-acquired medication complication data shows a 36% decrease in Australian hospitals over the 7-year period from 14-15 to 2021. This improvement suggests that efforts to mitigate risks of medication-related harm are having a positive impact. Pharmacists embedded in general practice and aged care settings are critical to stewardship programs such as those related to antipsychotics. Addressing polypharmacy, particularly when supported by digital health technologies, can reduce the risks of adverse drug events. The Commission has a rich catalogue of medication safety and digital health resources. These resources focus on digital health technologies, such as a guide to safe implementation of electronic medication management systems, software vendor information resources for medication charts, and My Health Record for medication safety, such as the use of pharmacist-shared medication lists. The Commission has commenced work to develop core clinical information requirements within a national electronic medication chart framework to support the safe and sustainable prescribing of PBS and rPBS medicines. The core clinical information requirements will provide a functional baseline for medication chart clinical safety to achieve consistency across aged care, hospital, and community settings where electronic medication charts are in use. A horizon scan of the digital future illustrates how embracing digital health technologies can improve the appropriate use and sustainability of medicines. Procurement resources can bring together safety elements and technical specifications, which can drive health services and software vendors to safer systems and reduce unwarranted variation in digitally enabled care. Digital health software systems must support healthcare professionals by treating usability and human factors as fundamental to patient safety. More content requires more navigability to avoid unnecessary cognitive burden on users. Health services and individual providers must reflect on how fundamental elements of clinical governance apply in a digital setting, such as seamless information exchange for medication reconciliation at transitions of care. Digital health technologies present both opportunities and challenges. How do we simultaneously harness its capabilities and maintain safety? This challenge becomes even more complex when considering emerging technologies such as AI. Clinical and technical governance frameworks must operate synergistically to ensure digitally enabled care supports the best possible patient outcomes. Governance frameworks will undoubtedly need to mature in lockstep with new virtual models of care. What is prototyped now will only proliferate in time. Digital health technology makes it possible to efficiently monitor and optimize medicine's use through data analytics. Digital technologies support more appropriate prescribing, monitoring, and access to pertinent clinical information at the point of care. Interoperable systems facilitate the seamless transfer of a patient's critical medicines information between care settings, which mitigates the risk of medication-related errors at transition points. Imagine healthcare without the digital health solutions that are commonplace today, the efficiencies earned, and the safeguards that have made it a stronger, more sustainable system. Continued efforts are required to achieve even greater medicine sustainability enabled by interoperable digital health technologies for connected care. Thank you.
Thank you so much, Paul. And next up, we have Professor Faye McMillan AM talking about how Aboriginal community-controlled health organisations are leading the way, not just in helping people connect to their culture and that driving better health outcomes, but also how it can drive sustainability.
Hello, my name is Faye McMillan. It's such an honour to join you today for the quality use of medicines, talking about sustainable systems. I would like to start by acknowledging that I am today coming to you from the Wiradjuri Nation, acknowledge traditional custodians past, present. I pay my respect to my elders of this land and any ancestors who have come before us and those that are with us and guide us today. I'd like to acknowledge any emerging leaders and also extend my Yinjamara or respect to any other Aboriginal and Torres Strait Islander people that will be joining us today. I'm coming to you today as the Deputy National Rural Health Commissioner for Allied Health and First Nations Health. The role of the National Health Commissioner, though, or the Office of the National Health Commissioner, is an independent statutory office holder that we work to a statement of expectations to the current Assistant Minister for Rural and Remote Health. And the purpose to improve the quality and sustainability of access to health services and professionals in regional, rural and remote Australia. The focus of the office, though, is advocating for health equity in rural and remote communities, the development of a sector-agreed definition of sustainable rural and remote multidisciplinary health teams, known as the Ngai-Bargadang Consensus Statement, as well as the promotion of models of care designed for and by rural and remote services, workforces and communities. As I said, my name is Faye McMillan and I'm a Wiradjuri woman from central western New South Wales in a small town called Trangie. My priorities are to advocate and promote opportunities for rural allied health workforces and high quality health services. This obviously overlaps with my work in pharmacy, Indigenous health, and particularly when we consider that we are not utilising either of these workforces to their fullest potential. I've been a community pharmacist now for over 2 decades and worked within the health sector for over 3 decades. So I am, as I said, particularly proud to be joining you today as a rural clinician that chooses to work and live in rural Australia. But today, the quality and safe use of medicines. It is a tool we have as a health system that can contribute to keeping people well for as long as possible in their communities or the environments in which they choose to live. And when this is no longer possible, how do we use that to ensure dignity and respect for the human as they move through our health systems? I see this as very much a part of a multifactorial or interconnected component, where the umbrella is the part that overarches, and each segment plays its role in creating that opportunity to ensure that we have coverage for times when things get rough. It's understanding policy, workforce, professions, as well as people and communities. When we look at a system as a whole, we can begin to build protective qualities and safe mechanisms that reduce risk and improve health outcomes for communities where and when they need them. Policy and workforce. It's about recognising the value of investing in building workforces that represent the communities in which they serve. This is understanding that each community, if you've been to one, you've been to one. The acknowledgement that Our communities are not homogenous, so therefore our responses to our communities must also not be homogenous. We need to understand growing the rural and remote health workforce should be a priority, and that growing the First Nations health workforce is another priority of this country. It is about ensuring that our disciplines and professions are made up by people that they serve, so that when they are seeking support and access to quality and competent care, that this is done through a workforce that is representative of the people. But how do we do this when, as I said, each section is its own pillar, but we need to weave these pillars or materials together to understand how we can create that umbrella that allows us all to safely sit under and provide opportunities for us to work towards the roles in which we seek to serve. At the professional level, I've recently just been involved in the Federation of International Pharmacy conference that was recently held in Brisbane. But it's understanding that at a professional level, there are multiple spaces in which pharmacists are employed or gain recognition and services. It might be pharmaceutical sciences, it might be pharmacy education, it might be in the pharmacy policy development, or it could be within community or hospital. When we understand that First Nations knowledge systems are complex and have been held for generations, then looking towards the First Nations knowledge systems to ensure that we're able to effectively engage with the tool of understanding quality use of medicines and safeties. It is about working within the pharmacy degree programs to increase First Nations recruitment and retention. This is not just about the staff, it is also about the future of the workforce. But we need to ensure that we're meeting that here in the current space. Another area is in the Leaders in Indigenous Pharmacy Professional Education, or the LIPI network, where this provides a platform for pharmacy education to sit alongside of pharmacy accreditation and then pharmacy registration to ensure that our workforces are culturally safe and that our students, or the future of our workforces, are going to be receiving the opportunity to be professionally engaged and therefore grow their own cultural safety capacity. But it's also about acknowledging where pharmacists are now. We can't change the education that's already been provided, but what we can do is complement or create synergies with continuing ongoing professional education that allows us to meet these complex needs. As I said, this is about understanding that we are in a cycle, and whilst we might be in one phase, we need to recognise the impact of that phase on the next. And as you can see through this slide, it continually goes around. There is constant overlap or intersection that we must be mindful of when we continue to work with education, accreditation, and registration that allows pharmacists to build their knowledge, skills, and behaviours necessary to be contemporary health professionals that are meeting the needs of all communities, but understanding the complex environments in which many people sit. For Aboriginal and Torres Strait Islander peoples, this is important that we see Indigenous leadership or First Nations leadership at every level of our systems and structures. This is through accreditation, the education, the registration, but all of the things that sit alongside of those that make the pharmacy profession one of the highly skilled workforces that we need to have a focus on. We must be responding to community need. 2 recent projects undertaken by the National Aboriginal Community Controlled Health Organisation, or NACCHO, have demonstrated pharmacists contributing to improving medicine adherence and health outcomes for First Nations people. Pharmacists entering the profession are equipped with the knowledge, skills, and behaviours necessary for contemporary practice. But we also need those skills to be flexible, to adapt to new scopes of practice as they emerge in areas such as I said, ACCHOs, the aged care sector, as well as the disability sector. These are expanding areas in which pharmacists and the skills of pharmacists and the intimate knowledge that pharmacists have with regards to quality use of medicines and safeties is critical, because we find Aboriginal and Torres Strait Islander peoples in all facets of our community. So therefore, we must represent that when we're responding to community need. The aged care sector and the disability sector have both recently just undergone royal commissions to understand the impact that this has on our communities and the people within those communities in which pharmacists become part of a tool or the tools that can keep people well for as long as possible in their communities. But improving the quality of services for rural and remote communities provides a nuanced lens. In rural and regional communities, pharmacists are often one of the only accessible health professionals that may be based within the community. These pharmacists working in the community are ideally placed to provide care that complements general practitioners, nursing, as well as other allied health disciplines. However, it is necessary to establish new standards to ensure the quality of training programs will support pharmacists expanding their scopes of practice. For example, training programs that support pharmacists to prescribe, pharmacists to provide care in residential aged care facilities. It seeks to use the skills that pharmacists already have when they either return to their communities that they may have come from, or they actively seek to work within regional, rural and remote communities. It is really important to understand that when we do this, we are enabling communities and individuals to be at the centre of the care that is provided. So when we talk about quality use of medicines and services that are safe, respectful and responsive, that this is what we are talking about, and that we can, when we come together, ensure that patient-centred care is provided where and when people need it. It is truly an opportunity to understand the work that we do, the skills and knowledges that pharmacists hold as medicines experts, but we are not the experts of the people that we work with. And so when we bring experts together, it needs to be in a way that is respectful and creates synergies that allow people to share their knowledge of what skills they bring to a relationship. So relationships are central to this, ensuring quality of services for all communities, but particularly for rural and remote communities. These relationships allow communities to feel that services and professions are accessible within their home and their home environments. And this is critical as we talk to the ageing population of this country and how we will meet those needs and allow people the opportunity to remain in their communities as long as possible so that they have their support networks and the engagement to keep them well, both physically, psychologically, and ultimately through a holistic view. As part of my roles, I often hold great privilege to be able to go and see the vast areas in where innovation and innovative models of care are being undertaken that allow quality use of medicines and safety to be put front and centre as part of the offering that the pharmaceutical profession provides to our communities, particularly when we centre patients at the centre of the care that is being provided. It is simply not good enough when we accept that for rural, regional and remote Australians that they should expect to receive subpar services, because we know that the professionals that are engaging in these communities are definitely doing the work to ensure that they have the skills, knowledge and are contemporary to the environment in which they serve. Here in Australia, we are currently in the midst of one of those opportunities that come once in a decade and potentially once in a lifetime. And creating that space that allows us to ensure that what we do today will be felt for tomorrow, but it also leaves space for us to respond to emerging needs as they come forward through understanding where we are today and how and when we want to be into the future. The Office of the National Rural Health Commissioner, though, is committed to ensuring that patient-centred care through the Naya-Bargadhan Consensus Statement as a multidisciplinary approach that centres the patient at the centre, but also ensures that those that are leading care with the patient is being done by a discipline that is in a relationship that then can coordinate other aspects that contribute to ensuring that the patient is able to remain well and live where they choose. This is not something that is easy, and Australia is not the only country that grapples with how do we ensure this. What we have is understanding the sustainability of the environments in which we work. That is the geographical sustainability, but it's also about supply chain sustainability. It's about workforce sustainability. It's about the opportunity for us all to understand what our roles and responsibilities may be in these moments and how we use that responsibility to respond with the actions that then become necessary to enliven the quality use of medicines and the safety of medicines for all Australians, utilising, as I said, the skills that the pharmaceutical industry brings to this space, but also acknowledging the First Nations people of this country and indeed around the globe as significant cultural knowledge holders that underpin the work that we do, and ensuring that when we put patients at the centre of their care as the experts of themselves, that we are able to do this. It means that we are then able to create belongings in systems that use our wisdom and our ways. It creates conversations that acknowledges the expertise that each party brings to the relationship of enhancing quality use of medicines and the safety of medicines within our communities. It's responding to patients where and when they need them. It is honouring the gift of true reconciliation by First Nations communities within this country, but it's also recognising the resilience of First Nations communities to work alongside organisations such as the Department of Health and Aged Care. It's also understanding the role of community-controlled organisations, but the role of the profession as one of the trusted professions that people engage with on a regular basis. And when we do create those belongings and people can see themselves in systems and structures and that their wisdom is respected and acknowledged, that we can truly ensure that the quality use of medicines and the safety of medicines within our communities is one that is held dearly by all of those within that relationship. So I do hope that you enjoy the rest of the conference, this opportunity to be part of a relationship across multi-factors, and going back to my umbrella analogy, that opportunity for us to find safety and collective well-being under that banner of the umbrella means that we will be able to ensure that when we provide quality use of medicines, that the safety of the individual, the community, the environment and culture is placed at the centre of all of that. As I said, I wish you well as you continue through. It's been a great honour to join you today, and I hope you find the space to talk to a colleague, a peer, mentor, understand what's your role in creating this belonging in a systems that recognises our role as pharmacists, our role as community, and certainly our role as those that deliver on policies that will inform how people feel and receive care within our communities. Wandangul, thank you very much.
We've heard so much today about the scale of the problem of sustainability or need for sustainability in medicines, and plenty of insights into how we could make it better. Let's home in on some really specific areas where people are innovating to be part of the solution to this problem. I'm joined by a fabulous panel of people, starting with Dr. Emily Sinnott, Medical Advisor, Sustainable Development Unit at Western Australia's Department of Health. Tony Riley, who's a pharmacist with the Return Unwanted Medicines Project, and Professor Branwen Morgan, Minimising Antimicrobial Resistance Mission Lead at CSIRO. Emma, we'll start with you. What are some of the non-pharmaceutical ways that we can reduce the use of medicines in the system?
Oh gosh, that's a really good question, and I guess it's where one of my real passions lies. We know most of the carbon embedded within clinical care is actually, or embedded within the hospital systems and health systems, is actually at the coalface of clinical care. So if we can actually do well to prevent disease in the first instance, or partner with our patients to care better for them before they're needing complex medical interventions, then that's going to not only improve their well-being, improve their overall health, but also help to remove emissions. So some of the things is just forming those really good relationships with primary healthcare, improving the social determinants of health, so safe housing, green streets, social services where they're required for people who have care needs. And then looking at some of these other things such as green prescribing, so GPs helping to prescribe nature, or social prescribing, so GPs helping to provide or prescribe social solutions to keep people healthy and well in ways that aren't pharmaceutically driven.
Yeah, and at the other end of the scale, if we have prescribed pharmaceuticals, getting the unwanted ones back is a real challenge. Tony, how have you implemented this with the Return Unused Medicines Project?
Well, interestingly, the Return Unwanted Medicines Project has been in operation for almost 25 years. So lots of people know about it, but lots more need to know about it. And it's a very simple project. It's run through community pharmacies. So all the pharmacies on the high street basically have got a special return bin that you won't see as a consumer. It's always under the supervision of the pharmacist and usually in the dispensary. But people can bring their medicines back, pop them, and the pharmacist will pop them in the run bin, and then they're incinerated as required by the various EPAs around the country.
What did it take to get something like that up and running, and what are sort of the enduring challenges with it?
Well, to get it up and running, really, it was very much about a couple of pharmacists' passion 25 years ago, and they got some funding through the government and had a small trial ran in the Hunter Valley. And then it was rolled out nationally about 3 months after that. So it's been operating around the country fairly successfully and fairly simply for a long time. I guess the biggest challenges for us is to make sure that as many people who have got unwanted medicines know about us, and that's a challenge in itself, just getting that message out to everybody, because let's be realistic, getting rid of medicines that you no longer want is not top on people's priority list of things to do. So getting it as an important thing in their mind is one of those things for us.
Yeah.
Challenge.
And Branwen, we've heard a lot today about policy and government and big industry stuff, but I'm really keen to hear from you on the role of commercialisation and spin-offs and that sort of more grassroots side of things.
Yeah, sure. Thanks, Tegan. I think that innovation piece is really important. So I might just reflect on the previous two speakers first. One is around the procurement piece and the green procurement that Emma speaks to. And that can extend through to medicine supply. So when we think about, and I'll be speaking, of course, specifically about antimicrobials and antibiotics, when we think about where they come from, they're manufactured in India and China. So antimicrobial resistance anywhere is antimicrobial resistance everywhere. So what can we be doing in terms of, those innovative products or services that can help to reduce the impact of manufacturing those compounds before they even get to Australia? I think that's particularly important. And then when it comes to things like the return of unwanted medicines, and Tony and I have had a bit of a chat about this, we talk about AI and how it's changing our lives now and what's going into those bins. And again, there's a lot of different medicines and pharmaceuticals that we don't want to end up in the environment. But how can we use some of these technologies to determine how much are we actually saving from going into the environment? And just to specifically address your last point, part of the role of the Minimising Antimicrobial Resistance mission is to look at enabling and accelerating the development, uptake and adoption of processes and products that can minimise drug resistance, so less people turn up at Emma's hospital.
Yeah, absolutely.
And I guess on that first point in and around using this, or looking at the supply chain and ensuring that you've got embedded with that criteria around social and environmental, security, so ensuring that there's good practice, that actually then feeds back nicely to my comment before in and around the determinants of health. So we live in a global society and our choices impact people in other places. So if you think of the harm that is created through supply chains, for example, that have modern slavery, malpractices, or environmental degradation in some of these other countries, then we're actually contributing to poor environmental and social determinants for health in those communities. So it really goes both ways. So those things can help us to reduce our harm, but also reduce the impact of our supplies on those other places.
Yeah, so removing harm from the whole production chain, not just here in Australia. So Emma, this session's really meant to be about innovation and sort of practical ways that it's already being done in different parts. You talked about things like green prescribing and social prescribing, which we know that there's a lot of evidence for, but it feels like it's quite a grassroots thing. How has WA Health managed to actually embed this in the system, and how could other jurisdictions emulate this?
Yeah, so I guess we're only starting our journey. We're really only starting our journey here, but one of our health services, the health service that I actually work at, has started to look at this patient journey way of approaching care. So we've got something that's called Surge Fit, Life Fit. So we know that patients that require complex surgeries, often if they're in poor health going into those surgeries, they require longer stays in hospital and have poorer outcomes as a result. So one of the things that we've tried to build for patient journeys is this program where before while they're waiting for that surgery, they get linked in with physiotherapists, dietitians, counsellors, social work, so we can help to, address some of those underlying health or social issues so that they're fitter, they're healthier, they're stronger, they're more socially supported. As they come into their surgical procedure, they might actually improve so much they don't need that surgical procedure. And then they've also built all of these things and these supports and these lifestyle practices that once they do leave, they achieve greater health in the long term. So it's this holistic healthcare process, which, that's they're not only surgically fit, but they're getting that life fitness up. It's a really great program.
Who coordinates that and who funds it? Because it sounds fantastic. It also sounds complicated and maybe expensive.
Yeah, so it's run by our the Health Service of South Metropolitan Health Service, and it was, a test for change or an idea that came through from one of our physios, so our advanced care physios, who kind of came up with this concept, and then got a whole group of stakeholders together to really workshop around that. And it's actually just run by the health service and funded by the health service. As part of that surgical patient journey, they do education processes to the patients, they do peer sessions to help build community and peer support into those programs. Again, that social prescription side of things that we understand in terms of not only mental health, but also physical health and well-being, that patients do better when they're socially supported.
And Bran, talk me through the practicalities of the sorts of innovations that you're doing in CSIRO.
Yeah, great, thanks. And I was going to jump in actually and add to Emma's points as well, because it's that risk stratification piece. If you know who's likely to do better coming out of a surgery, worse, you can intervene early on. And that goes right down to the level of what bugs and microbes we're carrying in and on our bodies when we enter the hospital system. We've heard from clinicians, for example, that we have really quite stable hospital-acquired infection rates these days, but it's that risk of what's coming into the hospital with the visitor or patient. So what can we do? Well, we can do genomic analyses on what people are carrying, for example, in their gut microbiome, and then feed that into risk prediction algorithms that include things like the demographics of the patients. But equally, at the other end of things, when you do get an infection, quite often we don't have the tools to rapidly say what that infection is being caused by. So, for example, some of our researchers at CSIRO at our eHealth Research Centre in Queensland are looking at what's called drug-bug mismatch. So we know you have to start giving antibiotics quite quickly, but what if then 24 hours later, when the results from the lab come back, you're actually on the wrong antibiotic? How quickly can you switch to the right antibiotic? And that, of course, linking back to what Emma was saying, influences the health outcomes for those people and patients.
So with this genomic analysis that you're talking about, it's incredible. Is that being used at scale anywhere at the moment?
It's not being used at scale, but there are a number of SMEs or startups, not so small startups anymore actually, in Australia that are very interested in what's happening in the microbiome, and even to the point where we think about what can we do to decolonize people that are carrying drug-resistant bacteria. Because, for example, all of us on this call could have drug-resistant bacteria in our gut, but of course we seem perfectly healthy. It's only when something else happens that we then suffer, adverse health outcomes. So there's a company called Microba up in Queensland again, and I'm talking a bit about Queensland because we're trying to do things in a pilot centre, but as many things as possible, and then work out how best to scale based on multi-interventions and multiple points of projects. So yes, they provide consumer services where you can see what's in your gut. And there's also lots of research organisations and universities that, again, are looking at, say, spinal cord injury cohorts that have a lot of urinary tract infections because they're constantly catheterised. What are they carrying? What's coming out? What's causing those infections? And why do they keep coming back from a genetics point of view?
But again, we're focusing on those at-risk populations.
Yeah, look, that's a really good way to start. Of course, as I mentioned, we can have drug-resistant bacteria in our bodies when we're healthy, and maybe in the future it might be that we travel overseas to there are, particular really nasty drug-resistant infections, and then we come back to Australia and we might need to take a cocktail of antibiotic alternatives to flush those bugs out of our system.
It is interesting in a symposium all sort of about like reducing medicines to be thinking about adding some in, but it would be that sort of prophylactic thing. We might come back to that actually, but Tony, I did want to come to you because the thing with the RUM project, as you said, is it's been running for decades. The innovation is sort of already out there, but the challenge seems to be increasing awareness. How have you been pushing that forward recently?
Well, in recent times, we've been working mainly through social media, to be perfectly honest, and that to some extent gets to some people but doesn't get to all people. We're obviously aware of the shortfall of that. But I think that the best way of people finding out about RUM is word of mouth. Pharmacies talk about it, staff in pharmacies talk to the customers, hopefully when they're getting their prescriptions about, returning anything that they don't need any longer. And it's really interesting speaking to people. People will pass the message on to their families who then, pass their message on to their social circles. So we find the most effective means of communication is people talking to each other about it. And it's a funny conversation to start with people. But Return Unwanted Medicines program's got a very nice shortened name, the RUM Project, so that gives you a very good talking topic. People often want samples, might be alcoholic, but it's not. So, yeah, there's lots of reasons, lots of easy ways for us to get the message out, but it's, it's a very slow process doing it that way, to be perfectly honest.
How do you sort of convey the urgency? Because I think the thing with word of mouth is it's so effective if people really get what the kind of stakes are with it.
Yeah.
And obviously that point of sale or point of prescription dispensing is where you kind of have that opportunity to interact with the consumer. What is the sort of message that you're hoping people are giving there that is going to stick in someone's mind and make them tell their friends and family?
Well, the big message we use is safety and inappropriate access to medicine. So we know there's a lot of admissions each year to hospital with people taking medicines inappropriately, be it an accident or intentional. Children are the ones who probably access the most medicines, but we're finding in recent times that it is the older people. Older people are our biggest consumers of medicines, and medicine's becoming quite complex and funny names for people. It's very easy for them to get them confused. So it's a big thing to try and get an older person to be mindful of that and respectful, so that they're not being treated like idiots. So it is a challenge to, pick your market and where you speak about these kind of things and how you speak about them.
Yeah. So,
Tony,
yeah, keep going.
Sorry.
Yeah. Sorry.
I was just going to say, Tegan, that Tony and I were speaking about this from the environmental side of things as well. And as we have our younger people being more concerned about the environment and loss of biodiversity, for example, you can feed that into the messaging. So if you're not returning those unwanted medicines, they are going into landfill. They are damaging the soil microbiome and everything that, gives us the good, healthy agricultural soils, because essentially the biosolids and things then get spread back on our agricultural land. So if we can have that message and we can link it to things that people want to do or are trying to do through government and through policies, like you mentioned at the start, the task force on nature-related financial disclosures, can we build it into that? And environmental, social and governance, and we get more action and a more collective action that have a really positive outcome for our planet and our people.
Yeah, absolutely. And it's a great little segue that you've just given me there, because before the session we asked people to submit their questions, and one question was about how do we recycle medication packaging and unused medications. Tony?
Well, recycling medication packages is a really tricky thing. Obviously, the cardboard boxes that things come in can be recycled in normal domestic recycling. The blister packs, as in the foil blister packs that the medicines are packed into, that's a very tricky recycling process. And there are a couple of companies now who are able to do it, but it's costly. And there's a few pharmacy groups that are offering people the opportunity to bring their medicines back, their medicine foils back, to have them recycled. But there's a cost associated with that, of course. And then, of course, we don't recycle medicines. All medicines are incinerated, high-temperature incineration, because of the safety profile associated with medicine recycling.
Is that the best way to be doing things?
Beg pardon?
Is that the best way to be doing things? To incinerate everything sort of carte blanche?
Well, I guess there's a safety issue associated with the medicine. Once it's left a pharmacy or left a hospital dispensary, unless it remains within the hospital, we really don't know how it's been stored. Medicines are temperature sensitive. They're also, in a lot of cases, not tamper-proof. And not that we've had this instance in recent years, but there have been instances where medicines have been bought in pharmacies and been tampered with. And when you say to somebody about, well, would you want to use a medicine that somebody else has had in their home? Most people are quite happy to say no. Whilst it may not be the most cost-effective way of seeing the end of a medicine, it's probably the safest.
And I guess it really speaks to that necessity to look at that waste triangle. So if indeed the only way we can safely dispose of unused medications is incineration, what are all the steps that we need to do before then to ensure that we are doing that to the least amount of medications possible?
Absolutely.
And so there's that reduce kind of philosophy right from the get-go. And then if we are, I guess, looking at that bigger picture again, if we are indeed manufacturing all of these medications, are we doing that in a way that is environmentally and socially sound? And so, yeah, it's just speaking to the way that this is actually a systems approach that is required And if we are indeed incinerating, are we using green energy to do that process? So lots of ways that we can actually green that that problem to the best that we can.
So a really great point here is where innovation can come into it, because we know there are systems that are being rolled out across the country around real-time prescription monitoring for serious drugs or drugs of potential abuse. And we often talk about the fact, what would it take? What would it take to know what antibiotics, for example, are being prescribed and distributed? Because if we can reduce the waste, if we can get better at using technology to understand where and when those medicines aren't going to be used and focus on the prescribing element, it sounds like a real opportunity to reuse and leverage some of government's current infrastructure.
Absolutely.
But Bran, personalised prescribing is also part of the solution here, isn't it?
Yes. So, I guess all prescribing you could say is personalised, but what's particularly interesting there, Tegan, is we're all different weights and sizes. We metabolise drugs in different ways. In fact, 70 to 80% of the drugs that we do take end up in our waste streams going into the environment. So if we could have the right tailored dose, if we knew when to stop taking a particular medicine, because our symptoms have cleared and we've got clear evidence that infection is no longer in the body, even if we could reduce from 5 days to 4 days with evidence, or from 7 days to 5, that's a huge impact. And the metabolism and individual metabolism is a real opportunity.
Definitely. Another question pre-submitted by the audience that I might actually put towards you, Emma, is how do hospitals nationwide try and reduce single-use plastics?
Oh, gosh.
This is a problem you can just fix instantly, right?
Oh, got that sorted already. Again, there's that whole supply chain kind of philosophy that we have to look at. So how are we, from right at the very beginning, trying to work with our procurement people and with our contracts team to build some of those criteria into that project or that program, or how are we actually saying, hey, look, this is something that's really important to us. If we're going to purchase off you, what are you doing to reduce that? That's one thing. The other thing is looking for, so single-use plastics are ubiquitous across the system. Our pill cups, our straws, our denture cups, the single-use catheters, the cannulas, everything is plastic, and some of it is actually necessary. So you can't remove those things, but what can we do to actually look at all of the other bits that are changeable? So paper pill cups, paper straws, recyclable or reusable kidney dishes. So one is working with supply chains, writing it into your contracts and your procurement processes, working with suppliers and industry to innovate for change or innovate for greener solutions, and then where those solutions are available, swapping them out. Reconsidering the use or the reuse of products that we have moved away from. So, for example, surgical gowns, those sorts of things. Can we actually get away from those disposables? It's not necessarily single-use plastics, but it's a single-use item, and move back to something that's got a longer lifespan, and also then working with product. So everything is packaged individually into soft plastics. So can we actually again work with our suppliers to consider packaging it differently? So there's all sorts of ways along that supply chain we can improve things. And then there are those recycling single-use plastic programs that have been out. Some of them have disappeared, unfortunately, due to issues with people taking that plastic. But can we actually look at local solutions to those problems? So we know, for example, climate change is locked in, and we know that's going to make supply chains and our service lines face challenges in the future. Rail lines might go out. We might have another epidemic or pandemic that requires borders to be shut. How are we finding local solutions, local manufacturers or local people who can actually help us innovate to use some of our waste for purpose. And that's something that we all need to start to think about how we can do better.
Absolutely. Another pre-submitted question for you, Bran. Antimicrobial waste, writes this person, can have a devastating impact on the environment, resistance rates, and on the sustainability of these medicines, as we've discussed. They ask, should the disposal of antimicrobial waste be managed in a manner similar to cytotoxic drugs?
Fabulous question, and we've been thinking about this ourselves and wondering what
Did
it
you
would
submit
take.
the question? Was it you?
No, I did not submit the question. But it's two things, right? So you could do that either on a voluntary basis. So then you'd have to assess the costs of doing so. So, for example, in a hospital environment, it might be more cost effective to do it in a large tertiary hospital than in a smaller hospital. Or you could be forced into a situation whereby you have to do it through regulation. Now, at the end of the day, if you're going to achieve the same outcomes, it doesn't really matter, but it depends definitely on the stakeholders involved and what they're going to do and how they're going to do it. But the key point is why. So what is the benefit as well? Are there better ways? How do you measure that taking those antimicrobials out of the environment are going to reduce resistance? And there are ways to do that.
The question you asked there is why, and that sort of seems to be the underlying theme of this whole conversation, is asking why before we do anything. Why incinerate, or why even prescribe something in the first place?
So I think dealing with antimicrobials and antimicrobial waste in the same way as cytotoxic drugs is definitely that should be something that's investigated. It may be cost prohibitive for smaller hospitals, for example, versus the large tertiary hospitals. But ultimately, you want to stop those antibiotics getting into the environment for two reasons. One is that they either create a hotspot, or what's called a selection pressure, for the emergence of drug resistance. And of course, we're all interacting with our environment every day, so there is an ongoing risk to people and animals that then live in that environment. But secondly, because they do disrupt the natural biodiversity of our land. And by taking them out of the environment, whether it's done through regulation or whether it's done voluntarily, is something we were very, very keen on.
Emma?
Yeah, and I guess it really does come back to that decision-making algorithm that we all have as clinicians or as people delivering healthcare, pharmacists, nurses, administrators. We're all part of this system. And what we're trying to do is balance that idea of supply and demand. And there's this great model that's been developed in the UK in and around the sustainable clinician. And that goes to anyone who's delivering healthcare. So at first, it's that preventative health piece. How are we ensuring that our patients are healthy and well and on country and cared for appropriately in community so that they don't necessarily need that health service? How are we empowering them, educating them, which Tony touched on previously in and around disposal of medications, but it's broader than that. How are we empowering them to look after themselves in the best way possible and to understand their health needs? And then how are we, when they do need help, delivering that healthcare in a efficient way, in the right place at the right time with the right sorts of care? And then if we do need to touch them with a medication, or if they need an intervention, how are we empowering ourselves and them in understanding if it's the lowest possible emissions cost and the lowest waste solution? And we don't have much of that data yet. We have a little bit of data in and around some of the metered dose inhalers and the anesthetic gases, but understanding the carbon footprint of that care, we don't know yet. And then as Bran was speaking about, how are we ensuring that if they are disposed of, what's the harm that's being created in that process as well? Because that then goes back to feeding into what are some priority areas we really need to look at when we are delivering care to minimise harm.
Emma, can I pick up on that point about the cost and the carbon footprint? Because it's something we struggle with. What if the cost to do something that's better for the environment is actually greater than what you're currently doing? And so therefore we have to look, like we do with medicines, at the social costs of misuse of a medicine, for example. I'm just curious to know how you might justify that.
So I guess it comes back to that idea of triple bottom line. So if there's a greater financial cost to something that's more environmentally or socially responsible, How do you balance those ideas? And I think, again, it's about understanding the benefit of that overall. So we know that, again, climate change is the greatest greatest health threat we face in the 21st century. Planetary health as a whole is a crisis we all face. Land degradation, biodiversity loss, emissions, these are all impacting our health now, but will continue to do so at an ever greater rate into the future. So I think what we actually need to understand is what is the true cost of anything? And economic cost is only one component of the cost of something.
I do need to chime in. Sorry, Emma. I do need to chime in there. We're nearly out of time. Before we wrap up, it is our last session for the day. If there's one thing that you hope the delegates take away with them in terms of thinking about how to innovate, what do you hope it is, Emma?
I guess looking at a system as a whole, I think we are too easily driven into reductionism, and sometimes it's necessary for us to kind of step back and not rush this process. So we need to understand unforeseen consequences of some of these actions. So really getting all of those stakeholders together, as many of the people and the voices that you need, the folk with disability, First Nations folk, marginalised communities, elderly, the young, get them all together in the room and let's problem solve this together. We are all, we are better together. So my I guess, point would be reach out, bring people together, and then let's try to work on something that is equal and able and just for everyone in these challenges.
Tony?
I'm inclined to agree with Emma, but I think one of the things too is that I always reflect on is everybody has a role in this, even though what you feel is a small role, it's still important, and don't give up on it. But I do strongly believe we need to work together.
And Bran?
I'm going to build on that connection and collaboration and togetherness message, because human, animal and environmental health are all interconnected. So we need to consider them all together when we're thinking about the solutions that we want to bring to market, for example, but also in terms of the end user and all the different stakeholders. So again, having them in the room and being involved in that decision-making around solutions.
It's a big challenge, but you've given us some real food for thought with innovative solutions. Thank you so much, Tony, Branwen and Emma.
Thank you.
Thank you.
Thank you.
So to unpack more about the role that GPs can play in this space, I have with me Dr. Lee Fong, who is a general practitioner from the Hunter region. Hello, Lee.
Hello.
When did you start thinking about medicines and the environment?
Well, shortly before this conference, I think
like 5 to 10 minutes ago.
Very shortly. Look, I have to admit, as a GP, I didn't really have my head in this space. I guess I didn't really have a grasp of how important this issue was, or what I could do about it, and if there was something I could do about it, and how much of an impact it would make. So until this conference came up, I hadn't really been thinking about it. And so for me, this has really been quite an eye-opener in terms of, I guess, changing. It's a mind shift. The paradigm for me has changed as a result of this.
So I feel like we can often feel like we're quite small cogs in a really big machine. Like, as one GP, sort of how much influence do you have? Has this sort of shifted for you as you started thinking about that?
Yeah, absolutely. I think that sense of, well, as you say, it's a really big, well, the world environment is a big thing. And so how much difference can one person make? And I think some of the examples given, say, the one that really stood out for me was the one that was given about inhalers and puffers. And I think, when I did the maths in my head, I think it was equivalent to, say, one puff is a bit like, potentially, like driving a kilometre in a car in terms of the emissions. And that's like, that actually makes a difference. So that whole idea of optimizing medication and the potential impact and what difference I can make in terms of my prescribing, suddenly it makes it much more tangible and much more real.
What about for consumers, like for the patients that you're advising, what can they be thinking about to be good consumers of medicines as well?
I think One, for me, perhaps, in some ways it's a similar sort of journey, just being aware that it can, or the impact that medication usage can have on the environment. I think that's probably the first step. The second step is having got that awareness, then maybe talking to their own doctor about what medications are on. Is it the right medication? Is it for the right dose? Is it for the right duration? Do they really have to be on this thing? So that's probably an aspect to it. In terms of looking at whether other treatments, medications is one thing, other treatments, are they really necessary as well? If necessary, do they get a second opinion? And of course, consumers can do their own research. So nothing to stop them from doing their own research. There's always Google. There's also other resources as well. I know the Australian Commission for Safety and Quality in Healthcare has got some consumer guide to looking up healthcare information. Black Dog Institute, Raising Children. So there's heaps of resources available. So making sure that they probably access a high quality source of information. And then, of course, if they've got any questions, speak to their doctor.
So as a GP who's recently become aware of this, what sort of conversations are you having with your fellow GPs about raising awareness and thinking about the role of GPs in this space? So
I think it is that sort of the dual element of, one, being aware of what the impact is, and then B, being aware of what we can do about that. And I think a really strong message that's come through in this conference is the idea that if we prescribe appropriately, then there is that dual impact in terms of A, it's good for the patient, and B, there's an impact on the environment. And so I think it's those conversations really just to be aware of.
Thanks so much, Lee.
Thank you, Tegan.
And I'd now like to welcome Professor Villis Marshall AC, the Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, to wrap us up for the day.
As Chair of the Australian Commission on Safety and Quality in Healthcare, I thank you all for joining us today. As we end this event on sustainable and quality use of medicines, I want to reflect on the invaluable insights and discussions that have taken place. It has been a valuable experience to witness the collective efforts of experts, researchers, policymakers, clinicians, consumers and industry leaders who have come together to address the urgent need for sustainable quality use of medicines to protect and promote both individual and population health. These discussions and presentations have highlighted our challenges and the remarkable solutions within our reach. Today we explored various dimensions of sustainable and quality use of medicines, delving into topics such as access to affordable medicine, the appropriate use of medicines and its relevance to sustainability, the carbon footprint of medicines, safe prescribing and de-prescribing, and the role of innovation in driving positive change. The depth and breadth of knowledge shared by our esteemed speakers have undoubtedly enriched our understanding of these critical issues. We have witnessed inspiring examples of organisation and individuals who have embarked on this journey, implementing innovative solutions that prioritise human health and environmental stewardship. The challenges we face are complex and multifaceted, requiring all the collective efforts of all, from governance and regulatory bodies to pharmaceutical companies, healthcare providers, patients, consumers, and the broader public. By fostering collaboration and knowledge sharing, we can leverage our expertise to develop comprehensive strategies addressing sustainable medicines, social, economic, and environmental dimensions. We are fortunate in Australia to have a National Health Sustainability and Clinical Unit, and as we heard from Professor Paul Kelly, a clear vision for a national health and climate strategy. I'm also proud of the Commission's work to develop environmental sustainability and climate resilience standards. These standards will support health services to assess their performance and ensure good governance of sustainable practices, including the safe and appropriate use of medicines. By aligning policy with sustainability goals, we can create a powerful catalyst for change and drive the transition towards a more sustainable healthcare system. Furthermore, the symposium has highlighted the significance of innovation and reform to maintain health and reduce our dependence on medicines. We have seen how technology can bridge the gap between urban and rural areas, providing remote communities access to timely, quality healthcare services. Telemedicine, mobile health applications, and wearable devices are transforming how we monitor health and deliver health care, ensuring no one is left behind. As we conclude this event, let us remember that the future of medicines may be promising, but it has its challenges. We must continue to address issues of affordability, accessibility, and equity in healthcare. We must prioritise health promotions, early intervention, appropriate use of medicine, sustainability, and environmental stewardship. Most importantly, we must always maintain sight of the human aspect of medicine, ensuring that compassion and empathy remain at the core of our healthcare systems. In closing, I would like to sincerely thank the Minister for Health and Aged Care, the Honourable Mark Butler, for supporting today's symposium, and I express my deepest gratitude to all the speakers, panellists and the participants who have made this event a resounding success. Your contributions have been invaluable, and your commitment to shaping a better future is commendable. Let us continue to push the boundaries of science, technology and sustainability. Let us work together to ensure that the future of medicine is good for the people and the planet. Thank you, and I look forward to witnessing the positive impact we can collectively achieve in the realm of sustainable and quality use of medicines.
Thanks so much, Vilas, and thank you to all of our speakers today and for you for coming along and taking the time to listen and learn. Thanks so much to everyone who submitted a question. We did get to as many of them as we could, but if your question didn't get answered, or even if it did, keep an eye on your email and on the Commission website where more information will be coming through in the next few days and weeks. For now, keep the conversation about sustainable use of medicines going and have a great evening. Bye.